Hi and welcome to a new episode of your weekly medical TV show on الكرمة TV, White Coat. Today's disease is a medical problem that has an overlapping picture with other disease. Today we'll talk about peptic ulcer disease. The main symptom of peptic ulcer disease is epigastric pain, which is a very common symptom for a lot of GI diseases. That's why the picture overlaps sometimes with other disease. What makes it more complicated sometimes that the patient medicate themselves by drinking some milk culturally or getting over-the-counter medication, which helps for a few days. It might help for limited time, but thinking it's a very simple hyperacidity sometimes makes it even worse. Lifestyle and processed food has direct impact on our today's disease. The mortality rate due to complication has decreased a lot in the last two decades. In peptic ulcer disease, it's my pleasure today to honor and host one of the two outstanding physicians in Southern California, Dr. Fairborz, and for the first time in White Coat, Dr. Selma Prechel, to teach us more about peptic ulcer disease and all lines of treatment. For interaction with the program, send in all your questions and concerns to our official Facebook page, White Coat Alkarma TV, or to interact with my guest directly today, you can call the numbers that will be shown on the screen at any time during the episode, and we'll be more than happy to answer all your questions. أعزائي مشاهدي قنوات الكرمة في كل مكان في العالم، أعزائي مشاهدي البرنامج الطبي وايت كوت، بحب أرحب بيكم في حلقة جديدة من البرنامج. والحقيقة حلقتنا النهاردة هتكون عن مرض مشكلته إنه بيتداخل مع نوع تاني كتير جدا من الأمراض، والصورة أحيانا ما بتبقاش واضحة في البداية. الحقيقة النهاردة هنتكلم على قرح الجهاز الهضمي، وتحديدا هنتكلم على قرحة المعدة وقرحة الاثنى عشر بالتحديد، اللي هم النوع من القرحتين اللي بنسميهم البابتيك ألسر ديزيز. والحقيقة انه ابتدوا يزيدوا في الفترات الأخيرة جدا نتيجة طبعا تغير ستايل الحياة، تغير نوعيات الأكل بناكلها، البروسيسد فود، الأكلات المصنعة. الحقيقة ليها جزء كبير جدا في زيادة النوع ده من الأمراض. زي ما أنا قلت قرحة المعدة والاثنى عشر بيبقى ليها صور كتير جدا، وللأسف أنه بعض ثقافتنا أنه جزء من الصورة المتداخلة دي معاها أنه دي زيادة في الحموضة، اشرب شوية لبن، خد أي حاجة اوفر ذا كاونتر هتساعد، وللأسف أنها فعلا بتساعد ليوم أو اتنين وبترجع نفس الأعراض تاني. والحقيقة أنه مشكلة قرح المعدة والاثنى عشر هنشوف النهاردة أن قرحة المعدة تحديدا أحيانا بتتحول لنوع معين من أنواع الكانسر في المعدة. فالحقيقة الفكرة كلها أن احنا نكتشف الصورة دي بدري قد ما نقدر قبل ما نوصلها لكتير من الكومبليكيشنز اللي ممكن تحصل وتؤدي لعواقب وخيمة جدا. بيسعدني وشرفني النهاردة أن يكون معايا اتنين من أفضل الدكاترة اللي عموما بتعالج الموضوع ده هنا وبتتكلم في الموضوع ده هنا. دكتور فاريبورز، والأول مرة في وايت كوت بتكون معانا دكتور سلمى بريشل. هنتكلم النهاردة زي ما أنا قلت على قرحة المعدة والاثنى عشر. حضراتكم من أول ما حطينا ده على الفيسبوك ابتديتوا تبعتوا لنا اوريدي الأسئلة، ولكن للتواصل معانا لو عايزين أي أسئلة في موضوع قرحة المعدة والاثنى عشر تقدروا تبعتوا لنا على صفحتنا الرئيسية على الفيسبوك وايت كوت الكرمة تي في. تقدروا تبعتوا لنا كل استفساراتكم، هنحاول ناخدها أثناء الحلقة ونجاوبها. لو حضراتكم ليكوا أسئلة مباشرة مع الاثنين ضيوفي النهاردة تقدروا تكلمونا على الرقم اللي ظاهر قدام حضراتكم على الشاشة دلوقتي في أي وقت من أوقات البرنامج، وهنكون سعداء إن احنا نرد على استفسارات حضراتكم. زي ما أنا قلت النهاردة هنناقش المشكلتين مع بعض لأنهم شبه بعض جدا في الصورة، وإن يعني اختلفت شوية الأعراض في كل واحد، ولكن هنحاول نعمل توعية كبيرة جدا لحضراتكم إن احنا ما نهملش الصورة البسيطة اللي هو أنا عندي شوية حموضة ونتعامل معاها زي ما أنا قلت بالثقافة الدارجة بتاعتنا، لأنه الموضوع ممكن يكون أكبر من كده بكتير. إن شاء الله ربنا يدينا حلقة حلوة النهاردة مع حضراتكم، مستنيين تفاعل وتواصل مع حضراتكم، ويلا بينا نبتدي فقرات برنامجنا النهاردة من وايت كوت.
Are you tired of being overweight? Do you suffer from diabetes? Do you suffer from hypertension? Do you suffer from obstructive sleep apnea? Do you suffer from hypercholesterolemia? Have you suffered from heart attacks in the past? Strokes in the past? Are you tired of being ostracized in public? Well, I have a solution for you. Robotic bariatric surgery. This can completely change your life. I'm Dr. Bobby Baskerville. I'm a robotic bariatric surgeon. I do robotic weight loss surgery, which can completely change your life. I offer 3 different types of surgeries that can completely change your life. The sleeve gastrectomy, the lap band, and the Roux-en-Y gastric bypass. One thing that's very unique about our program is that we have a dietitian, and you will get counseled on what to eat, what not to eat, and how to optimize the utilization of your tool for good weight loss.
Hi, I'm Dr. Selma Prechel. I was born and raised in Detroit, Michigan. I went to Laura F. Osborne High School. I received a 4-year merit scholarship upon graduation and went to Wayne State University. From the university, I went to Michigan State University College of Osteopathic Medicine. I graduated in 1994. From there, I went to join the Bi-County Henry Ford Osteopathic Health System and did my internal medicine residency. Upon graduation, I was offered a teaching position in the residency program. I gave that job up to join my husband, Dr. Fairborz Shams, who was working in Anaheim. We worked together in an internal medicine practice in Anaheim, California. We consider ourselves a dynamic duo. We work very well together and have built a very productive practice. We subspecialize in general internal medicine with geriatrics. I love doing medicine because ever since I was a child, I've wanted nothing more than to be able to help people. As a doctor, I thoroughly enjoy teaching my patients. I treat all of them as family. I try to teach my patients about their disease process so that they're fully aware, and we work out a plan to get them to the best health they can possibly be. In my free time, I love gardening. It's the best medicine. I really unwind and become one with nature. My second hobby, and most favorite of all, is spending time with my family and my 2 children, Brandon and Melanie. Thank you.
Hello, my name is Dr. Fairborz Shams. I was originally born and raised in Tehran, Iran. I moved to the United States in 1976 and actually moved to Anaheim. I started my high school here in Anaheim, Lower High School, and graduated from high school, moved on and went to University of California, Irvine. I'm coming from a background of physician from generation and generation going back about at least 200 years. I have had every family member from the kings of Iran until me being a physician. So being a doctor have always been in my blood, and I have always looked up to my uncle, who was a great orthopedic surgeon back in Iran, and moved to Anaheim too. I finished up my undergraduate at UCI and basically moved on to Kansas City, Missouri, and I did my osteopathic medical education and graduated with the Doctor of Osteopathy from Kansas City, and that's when I moved to Detroit, Michigan to do my residency. I did 3 years of internal medicine residency, and that's where I met my beautiful wife, Selma, who was actually, I was the chief resident at that time, and she was starting her residency program. After I finished my chief residency at Michigan, I became board certified and moved back to where I started in Anaheim. And The hospital that I'm working with is West Anaheim, and interesting, this is the hospital that when I was going to high school, I used to work as a phlebotomist. Now, I came back as a physician. I've been working here since 1995 in the hospital. I've been through a lot of different roles. With the latest one, I'm chief of staff at the hospital. And my wife actually came and joined me in internal medicine. She's an internist also. Now we have this practice in Anaheim. And my goal have always been to take care of the patient. And one of the requirements that I talk to my patient about is I consider them as my own family, and I want them to feel like they are part of me. We have a very good relationship with each and every one of my patients. I've been taking care of them ever since they were kids. Now for 25 years, they're adult, and it's always been a joy. And that's a reward that I get. Other things that I have been doing here, about 4 years ago, I started internal medicine residency program at West Anaheim. Ever since I came to Anaheim, I really wanted to give back to the community, to help people. These doctors taught me, and I thought this is my responsibility now to teach them. So I have started a residency program, internal medicine 3-year residency program, and I have already have 2 graduate class. We're going into the 3rd year resident, and I'm happy to say they're outstanding. They have gotten fellowship position. They have started other practices throughout the country, and we're becoming top-notch, one of the best internal residence program. I have been always there, and I'm looking forward to be here again and taking care of all my family members in Anaheim. A few weeks ago, I was contacted from White Coat TV, and to be talking and maybe reaching out to more patients, trying to help as much as I can. And I was very receptive. This is in line with what I do believe in, to giving back to community, to giving back to the people and helping people out. And I really like the idea, and I'm very enthused to do that. See you on White Coat on Alkarma TV.
أهلا بحضراتكم مرة تانية في الجزء الرئيسي من حلقتنا النهاردة اللي هنتكلم فيه على قرحة المعدة والاثنى عشر. زي ما قلت لحضراتكم الحقيقة ابتدى يجيلنا أسئلة. إذا تقدروا حضراتكم ليكوا أي استفسارات تبعتوا لنا على صفحتنا الرئيسية على الفيسبوك وايت كوت الكرمة تي في. بتقدروا تبعتوا لنا كل استفساراتكم أو أسئلتكم عن مشكلة قرحة المعدة والاثنى عشر بشكل عام، أو تقدروا حضراتكم تتكلموا على الأرقام اللي هتظهر قدامكم على الشاشة لو ليكوا أي سؤال دايركت مع الضيفين بتوعي النهارده. It's my pleasure and honor to welcome for the first time on White Coat Dr. Selma Prechel. Ladies first, welcome Dr. Selma, and thank you so much for being on White Coat.
Thank you for having me.
Dr. Fairborz Shams, one of White Coat family already. Welcome back, Dr. Shams.
Thank you for the invitation.
Today's problem has an overlapping picture with a lot of other diseases. We're talking off air about it. So in the beginning, let's start with Dr. Selma Prechel about what's the definition of peptic ulcer? When we say peptic ulcer disease, what does it mean?
We're talking about usually a circumscribed or circular ulcer of the GI inner layer of the stomach or the duodenum, occurring in areas that are exposed to the stomach acids or the pepsin, and it's most oftenly caused by a bacterial infection by the bacteria H pylori.
So the protective layer of the stomach is gone?
That's the inner mucosa.
Okay.
The most inner layer.
Okay. And when you say it's an infection with the Helicobacter pylori, is it a bacteria or?
It's a bacterial infection.
Okay. الحقيقة سؤالي الأولاني دكتور برشيل كان عن إيه هي فكرة القرحة؟ إيه هي القرحة أساساً لما بنقول قرحة في المعدة أو قرحة في الاثنى عشر بشكل عام؟ إيه هي القرحة؟ فقالت القرحة إنه هي الجزء المبطن أو الغشاء المبطن للمعدة أو الاثنى عشر بيبقى فيه يعني بيحصل فيه مشكلة، أو الجزء المبطن ده بيروح تماماً من القصة دي نتيجة زيادة، ممكن تكون زيادة في الحمض كمان المشكلة الأساسية غير زيادة الحمض اللي احنا بنتكلم عليها بتبقى في حاجة في نوع من البكتيريا اسمه الهيليكوباكتر بايلوري، والحقيقة دي موجودة بشكل كبير جدا، وللأسف عشان احنا مش بنخضع لفحوصات ليها فكتير جدا مش بتبقى يعني مش بتبقى واضحة بالنسبة لنا، ومش بنتشخص بيها، وكتير من الناس بيبقى عندهم المشكلة دي، ونتيجة عدم وجود الحاجات اللي تساعدنا على تشخيصها، وبالتالي كتير جدا وبالذات في دول الشرق الأوسط مش بيتم تشخيصها بالشكل السليم. Would you walk us through like some pictures, tell us how does it look like and all that stuff in slide 2? Slide 3.
Okay, there we go. If you look at the left picture, you'll see that it's a pretty circular type ulceration or crater that you'll see that's the inner mucosa of the stomach.
Okay.
And on the right side, you see it's an ulcer, also an ulceration, but it's getting deeper into the layers of the stomach, the mucosa, which is the most inner. Then you have the submucosa, which is the second, and the third would be, if it erodes through, would be through the muscular layer, which is a complete perforation.
Okay. So that's how it looks like in the stomach or in the duodenum.
In the duodenum.
اوكي. الحقيقه حبينا نجيب لحضراتكم صوره عشان برضو يبقى عند حضراتكم الامبريشن او ايه هي فكره القرحه بشكل عام. زي ما احنا قلنا اللي على الشمال، الجزء اللي على الشمال دي بتبقى القرحه بتاع المعده، الجزء الابيض اللي فوق ده الدايره البيضاء دي هي دي فكره القرحه بشكل عام. زي ما احنا بنقول لحضراتكم انه الجدار المبطن للمعده نفسه بيحصل فيه القرحه اللي قدام حضراتكم دي. اللي على اليمين الجزء الابيض ده هو قرحه الاثنى عشر، القرحه اللي بتحصل في الاثنى عشر زي ما حضراتكم شايفين بتبقى مؤلمه جدا. يعني هنقول كل التفاصيل مع حضراتكم، هنتكلم على طرق العلاج، ازاي كمان نغير طريقه حياتنا واكلنا عشان قدر الامكان نقدر نتجنب الفكره دي. Dr. Shams, is there like different locations for the ulcer in general? And if you want to walk us through some statistics to realize how big is the problem that we're talking about?
The problem is big, but to start with, I'd like the audience to know basically the anatomy and the function, and that's why I like, you have stomach, the function of it is to mixing the food and acid and passes through the intestine, which is duodenum. So what happened, as Dr. Prechel said, you have two different kind of ulcer, and you have ulcer that appear in the stomach and also that appear in the duodenum. So if you go, duodenal ulcer is about 4 times as common as the gastric ulcer. And it's most common in the middle-aged people. It usually peak around 30 to 50 years old.
Okay.
And it's the male to female ratio is more prevalent, so you had more guys getting it than...
We're less lucky then.
Guys are always lucky, what can I say? And the genetic link is 3 times more common in the first degree relative.
Okay. So somehow it has some inheritance element.
Inheritance, exactly.
Okay.
And it's more common in patients with, interesting, with the group blood type O patient. It associates increase with serum pepsinogen, and that's enzyme that's secreted in the stomach. And Helicobacter pylori infection is very, very common.
Okay.
And I'm going to take a little bit of time to explain that because that's very important. And it's up to 95%. Smoking makes the ulcer 2 times higher incident. Now, I said about Helicobacter pylori, and I'd like to give a little bit of history on this, and it's basically scientific. The doctor in Australia, New Zealand, they knew this, but nobody believed it at that time. And what they did is very incredible. They won a Nobel Prize on that, and they drank the whole Helicobacter pylori bug, and the endoscopy showed that how it's related to causing gastric ulcer.
Okay.
So
did they make it alive though after?
Yeah, they're still that's how they got the Nobel Prize for that and treatment. So that is very important for people to know. It is a real thing.
Okay.
It is, and it's, as Dr. Prechel said, and we'll go over it again, it's very common Middle East, socioeconomic, and all those kind of things. It's becoming #1 cause of the ulcer, basically, among other stuff. But anyway, so stomach is, smoking is very important.
Does it have a preference, like location-wise in the stomach, like part of the stomach?
As far as the ulcer, basically, it's more, peptic ulcer is more common in duodenum, which is the small, beginning of the small intestine. So as I said, when you have food, you eat, it goes to the stomach, and it gets mixed up, and it passes to the small intestine, that's duodenum. So the ulcer is more common in the small part of the small intestine, but having a Helicobacter pylori infection, it needs, so it's in the stomach, so yeah.
الحقيقة سؤالي دكتور شمس كان يعني عن ايه هي الانواع اللي موجودة عندنا، ايه هي الحاجات يعني اللي بتيجي اكتر من التانية، كمان لو نقدر زي ما احنا متعودين مع حضراتكم كل برنامج وكل مرض بنحاول نروح للإحصائيات عشان نشوف قد ايه حجم المشكلة او حجم المرض ده على مستوى العالم. فالحقيقة زي ما هو قال في مكانين، المكان الأول زي ما احنا قلنا هو المعدة، المكان الثاني هو الاثنى عشر زي ما اتفقنا. الحقيقة زي ما هو قال إنه السببين الرئيسيين يا إما زيادة الحمض يا إما البكتيريا اسمها الهيليكوباكتر بايلوري. قال كمان إنه التدخين بشكل عام من أسوأ العوامل اللي قد تؤدي إلى زيادة أو حدوث الأول القرحة، وكمان إنها مش يعني فكرة العلاج بتاعها بيبقى صعب جدا. وكمان قال إنه تقريبا إنه التدخين بيضاعف حدوث فكرة قرحة المعدة والاثنى عشر. كمان حاجة تقريبا مهمة بتحصل في حوالي ب10%، يعني 1 من كل 10 من السكان تقريبا. في كمان في الإحصائيات بتقول إن 4.5 مليون في السنة، 4.5 مليون شخص بيصابوا بالفكرة دي. في كمان نقطة مهمة جدا قالها دكتور شمس، إنه القرحة الاثنى عشر أكتر حدوثا بكتير جدا، ولكن الانفكشن بتاع البكتيريا بتاع الهيليكوباكتر بايلوري أكتر حدوثا في المعدة، أو في المعدة أكتر منها في الاثنى عشر، وده مهم جدا جدا جدا. Dr. Prechel, since it has 2 locations, we talked about the gastric and the duodenum. Can we put them like in a quick comparison to see like which one is worse, which one is more common, and all the other sides?
If you go to slide.
The comparison between.
Okay, so in duodenal ulcers, they're 4 times more common than gastric ulcers, and it peaks usually in the middle age, from 30 to 50 years old. And there's a genetic link with family because it is spread through saliva, utensils. It can be through foods. So
I'll stop you here at one point. If one of the families infected already with Helicobacter pylori, they need to make sure they don't share utensils or any of that stuff.
Right, because it is spread through saliva. Any body fluid, actually, it can be spread. Like, say someone is sick.
Okay.
So it could be spread through, like if a patient has the flu, it can be spread, widespread during that time.
Okay. So don't share utensils. What else about the duodenal ulcers?
They're more common in patients with blood type O, and they have an increased serum pepsinogen in their gastric lining. And it's also 95% more common. You'll see the H. pylori infection in the duodenal ulcer, as you'll see later, compared to 80% in the gastric ulcer.
Okay.
And it's twice as common you see with smokers because it decreases the protective lining of the inner mucosas we talked about earlier. And then as with the gastric ulcers, it's more common in later middle ages. And the female to male ratio kind of levels out during that time. You don't see such a big difference. It's a 2-to-1 ratio.
Okay.
And it's more common with people with the type A blood.
Okay.
And then you'll see it in the gastric ulcers more common with NSAIDs, or also known as like ibuprofen, Aleve, Motrin. So
here, like, I want you to advise our viewers today, just don't keep popping up Advil and Aleve and all
every time you have an ache or pain, you have to bear a little bit. NSAIDs do damage over time. The more exposure that is given to the mucosal lining, the greater the increase of developing gastric ulcers, especially later in life.
When we say, because NSAIDs is a little bit of a more complicated medical term, can you give us examples what NSAIDs are that's over the counter?
Yeah, like I was saying, like ibuprofen. People know like ibuprofen, Motrin, Aleve, Advil. Those are the type of drugs that fall under that category of NSAIDs.
Okay. So can we put them like in a quick comparison, like which one is more common, incidence and anatomy and duration? All that
if we could look at slide 8,
okay,
you see that the incidence is more common with the duodenal ulcer than gastric ulcers.
Okay.
And usually, like as Dr. Shams said, that the duodenal ulcers usually are in the first part and the anterior wall. And in the greater curvature, as you have your stomach, like you see, think of it as a cradling your baby, that bigger curve you would see because the acids just sit there.
Right.
And then even taking these medications, they sit there when they're dissolving and they erode.
And it's a gravity issue too. Right.
And then it's rare to see malignancy or cancer with the duodenal ulcer. It's more common with gastric ulcers. They could be either benign or malignant.
Okay. So the duodenal ulcer is more common, but gastric ulcer has more complications or it can get worse too.
Right.
Like,
it's more severe.
Okay.
Where it leads to malignancy, cancer.
اوكي. الحقيقه انه سؤالي لدكتور بريشيل كان عن خلينا نحطهم في مقارنه عشان نوري حضراتكم كل واحده نسبه حدوثها قد ايه، بتحصل في مين اكتر من الثاني، لانه ده مهم جدا. فهي ابتدت الحقيقه بقرحه الاثنى عشر وقالت انه هي قرحه الاثنى عشر بشكل عام بتحصل 4 مرات اكتر من قرحه المعده. فمعظم البيشنتس يعني هيبقوا عندهم قرحه اثنى عشر اكتر من قرح المعده. بتحصل او البيك بتاعها او بتوصل للقمه بتاعتها عند سن 30 ل 50 سنه. والحقيقه الرجال بيصابوا اكتر من السيدات 4 مرات تقريبا. مهم جدا انه كمان قرحه نتفاهم ان قرحه الاثنى عشر زي ما احنا قلنا قبل كده انه التدخين بيخليها مرتين اسوأ في يعني في الاعراض اللي هي بتحصل بيها، وكمان في الكومبليكيشنز اللي بتحصل نتيجتها. لو جينا لقرحه المعده هنلاقي انه هي حدوثها اقل، ولكن بتبقى مع نقطه مهمه جدا، والحقيقه انا وقفتها في النقطه دي ورساله هامه جدا لكل المشاهدين من فضل حضرتك. مش كل صداع، مش كل شويه الم نروح ناخد مسكنات. ولما بنتكلم على المسكنات بنتكلم على الادفل او الاليف او الايبوبروفين او البروفين بشكل عام. عيله بروفين كلها بتسبب قرح للمعده بشكل كبير، خصوصا اذا اتخذت من غير اكل. فمن فضل حضراتكم فكره ان احنا مع كل الم يحصل ان احنا نقعد نبلبع في حبوب من غير لازمه ملهاش اي معنى، لانه قد تؤدي الى قرح المعده. فمهم جدا ان احنا يعني نقف عند النقطه دي ونأكد عليها كويس جدا. مش كل صداع، مش كل الم بس نقعد نبلبع حبوب ومسكنات وخلاص، لانه ده فعلا بيبقى مضر جدا. الجدول المشهور اللي حطيناه قدام حضراتكم اللي بيقارن ما بين الاثنين في سلايد 8 زي ما احنا قلنا مع حضراتكم، اللي على الشمال دي اللي هي قرح الاثنى عشر، اللي على اليمين قرح المعده. زي ما شفتوا حضراتكم عشان نلخص كل اللي قلناه، قرح الاثنى عشر اكثر حدوثا من قرح المعده، بتحصل في الجزء الاولاني من الاثنى عشر. قرحه المعده بتبقى موجوده اكتر في الجزء اللي تحت من المعده بفعل الجاذبيه الارضيه. قرح المعده بتبقى تتحول اكتر انها تبقى مزمنه. قرح الاثنى عشر ممكن تبقى مزمنه او حاده بشكل عام. الحقيقه ودي نقطه هنتكلم كمان عليها النهارده في فكره التشخيص والعلاج. قرح الاثنى عشر من رير جدا انها تتحول لكانسر، ولكن قرح قرح الاثنى عشر صح من النادر جدا انها تتحول لكانسر، ولكن قرح المعده بيحصل فيها احيانا انها تتحول لكانسر وبتبقى شيء خطير جدا. فمهم دايما ان احنا زي ما انا قلت في اول الحلقه مش كل حاجه نقول دي حموضه وخد بس اشرب شويه لبن ولا بتاع والدنيا هتمشي. الحقيقه ممكن يحصل complications كبيره جدا. جزء منها ان احنا بنحاول نوعي حضراتكم النهارده ان مش كل حاجه يعني ناخدها ببساطه كده. So we talked about the statistics. Now we know how big is the problem. So why does it happen? Like, where does it come from? And the risk factors that we can work on, and the risk factors that we have nothing to do with. So can we talk about where does it come from and the risk factors as well?
Yeah, so the etiology of peptic ulcer is basically, you have to understand, it's ulcer. So the mucosal in the stomach or in the duodenum, when it starts getting eroded and the acid eats through the membrane, the mucosa is basically inner lining of the stomach or duodenum, and it's about 3 millimeter or greater, then it starts making hole. And the important thing that causes this thing, as I said before, is like having infection, Helicobacter pylori, number one cause of it. Other things, like Dr. Prechel was saying, non-steroidal anti-inflammatory drugs, people know as Motrin, Advil, ibuprofen. Those are the ones that eats through the stomach lining and duodenum, and basically give you that, created the ulcer that we saw before. Acid and pepsin. Additional aggressive factors as smoking.
Okay.
One of the things is smoking will aggravate the ulcer and makes it worse and increase the secretion, causing that crater there. Drinking alcohol, taking steroid. And one of the most important thing to me, and I know, is basically stress. Stress have a lot of contributing factor to that.
Okay.
So now the important protective factors, the mucosa. If the mucosa, the inner lining of the stomach, become protected either by neutralizing the acid or basically helping the lining, that would help the ulcer. Okay. Other risk factor that as we age, you know, the lining become thinner, skin become thinner within the whole body. So aging after 50 years old is basically.
So you talked about smoking. How about alcohol? Since
alcohol, yes, alcohol is pretty important. My philosophy is actually everything in moderation is okay. However, and we're going to go through it later on, but if people tend to go excessive, as Dr. Prechel was saying, I mean, if you have a headache, taking on popping up a Motrin every single time, 16 Motrin a day, it's not good. But if
don't
you have
kill a
every
fly
once in a
with a
while,
gun.
yeah, I mean, if you have one glass of wine or alcohol, it's okay. Not saying you have good. Always remember, we talked about it before, quality better than quantity.
Okay.
So you have to have a quality. If you want to have a glass of wine or beer or whatever here and there, it's okay. But we get into problem when people start drinking
like pint of vodka.
Pint. And when I say one glass, to my patient always they tell me one glass. I say, how much is the glass? And the glass is this big.
So
I'm not talking about that big of a glass, regular glass. So moderation is very important.
Any other medication that has effect on?
Things like basically besides non-steroidal is like steroids.
Okay.
People who have asthma, COPD, tend to take a lot of steroid, and steroid tend to chew up the inner lining also.
Calcium channel blocker, does it have an effect?
Calcium channel blockers are important factor too for blood pressure that affect the mucosa, and it is important to know that. So,
okay.
But your doctor needs to know all these things, so they need to communicate with your doctor all these things that you take.
How about the diet factors, our lifestyle? Does it have a factor in?
Yes, as I said, the stress is very, very, very important. If you're not relaxing, you're not eating the right way, the right thing, acidic food will cause that.
Okay.
Sometimes we try to help the symptoms, and like I'm pretty sure when you get pain and stuff, Grandma used to say, "Go have some milk, or then you will feel good." And
yeah, I was about to ask about this. What do you think? Drink some milk and everything will be okay.
And it is interesting because they find out actually milk in the long term, if you have ulcer, it makes it worse.
Okay.
It is true when you drink milk, if you have gastric ulcer, what happens is what happened is
It relieves
temporarily relieves the pain.
but on the long term, it's not
However,
good.
on the long term, what happened, the calcium in the milk will make the receptor in the stomach produce more acid and actually aggravate your ulcer. So you need to be careful.
How about caffeinated beverage? Caffeine.
Caffeine, the three things that really aggravates it, the most thing that you need to know is one thing is caffeine, is aggravate the ulcer. Number two is alcohol.
Okay.
Number three is tobacco.
Okay.
The very, very important, that aggravation factor. Now, other stuff, as I said, like non-steroidal, like calcium, they do have, and genetic factor obviously is part of it too.
What about soda, carbonated beverage? Does it make it worse, better?
Oh yeah, definitely, definitely. Carbonated have calcium again. It's just like, so I definitely stay away from carbonated.
What about cultural food, spices, hot food?
Again, go back what I said before. Quality better than quantity.
Okay.
I'm not asking anybody to just, you know what?
Stop it.
Stop it, you know, because that's not realistic and that's not going to happen. So moderation is good. Yes, cultural food, spices, even the tomato, pizza, spaghetti, you know,
Can make it worse.
Makes it worse, but that doesn't mean you'll stop it. So those are very, very important. There is another one that is very rare. It's a disease called ZE syndrome or Zollinger-Ellison syndrome. That's when the body starts secreting too much acid, and consequently you get an ulcer. Okay. So that's another factor.
Okay. My question to Dr. Prechel, statistics are saying women consume weight loss products more than men. What do you think about the apple cider vinegar? Because we got a question.
Yeah, nowadays the fad diets are lemon, water every morning, and now the new thing is apple cider vinegar for fat loss.
Okay.
The studies are showing now that instead of actually helping yourself, you're actually creating more problems because it increases the acid in the stomach.
Okay.
And if you already have issues where the inner lining of the stomach is irritated, basically vinegar is acid.
Okay.
It's a burning, caustic agent, and it irritates it and escalates the symptoms.
So it's not good?
It's not good.
Okay.
Studies are saying that it should be eliminated totally.
Okay. I have another question here because you mentioned asthma and steroids. They're asking if they're taking inhalers, does it have the same side effects on?
Yeah, actually, that's a very good question that ask. And the reason that came out for COPD that they use inhaled steroid is rate of absorption of that steroid is not as much. Okay. So it's pretty safe to do, and it's actually the steroid itself that come in touch with the lining of the stomach that causes the problem.
So we're talking about systemic oral steroids?
Or I'm talking about when you take it orally, prednisone.
Okay.
But the one that you prefer to use, it's pretty safe.
Okay. هي سؤالي الحقيقة كان طويل جدا، آسف يعني الإجابة أحيانا بتبقى طويلة جدا، ولكن هترجم كل اللي اتقال لحضراتكم. كان سؤالي لدكتور شمس عن إيه هي مسببات أو العوامل اللي بتساعد على زيادة قرحة المعدة والاثنى عشر بشكل عام. فقال رقم واحد في الريسك فاكتورز دي هي الإصابة بالهيليكوباكتر بايلوري زي البكتيريا اللي احنا المشهورة جدا اللي اتكلمنا عليها. نقطة ثانية اتكلمنا فيها إنه فكرة المسكنات اللي هي الايبيبروفين او الموترين او الاليف او كل الحاجات اللي موجودة على الكاونتر كمسكنات طبعا بتساهم بشكل كبير جدا في قرحة المعدة. نقطة ثالثة مهمة جدا فكرة العلاج بالاستيرويدز أو الكورتيزونات بشكل عام أو البريدنيزون. والحقيقة جالي سؤال هنا من مينا إذا بيتكلم على الاستيرويد. لما بنتكلم على الاستيرويد أو البريدنيزون فإحنا بنتكلم على الحبوب اللي بتاخد بق، إنما البخاخات ملهاش علاقة، لأنه كتير من مرضى الأزمة بيبقوا على بخاخات فيها ستيرويدز أو بريدنيزون أو كورتيزون. فالعلاج بالكورتيزون طول ما هو بخاخات ملوش أي تأثير في فكرة القرح، ولكن العلاج اللي بيتاخد بالبق أو الحبوب ده هو اللي بنتكلم عليه. طبعا حاجة مهمة جدا، العامل الوراثي بيبقى شيء مهم. كمان زيادة الكحوليات بتبقى ليها علاقة بالموضوع ده طبعا، واتكلمنا عليها كل حلقة، وزي ما أنا بقول مش بزهق إن أنا أتكلم عليها. التدخين، لأنه التدخين مش بس بيساعد على إنه الطبقة اللي بتحمي المعدة دي تتآكل ويسبب قرح في المعدة والاثنى عشر، ولكن كمان بيصعب مهمة الهيلينج أو إنها تطيب نتيجة حتى مع الأدوية. فبنلاقي ناس كتير جدا عندها قرح وما زالت بتدخن، مهما تديها في علاج ما بتخفش. فمهم جدا إن احنا نتوقف على التدخين. اتكلمنا كمان على الأكل، لأنه الأكل ده جزء مهم جدا. نتجنب تماما الحاجات اللي فيها كافيين زي الشاي والقهوة. دكتور شمس قال كمان إنه الحاجات الصودا بشكل عام نتجنبها تماما، لأنه بتساهم في زيادة قرح المعدة. كمان من الحاجات اللي اتكلمنا عليها بشكل كبير جدا المنتجات التخسيس. والحقيقة دكتور بريشيل قالت فكرة انه السيدات بشكل كبير هي اللي طبعا بتتناول يعني منتجات الويت لوس او التخسيس اكتر. طبعا كان في سؤال هنا من مدام ميرفت بتسأل على الليمون على المية سخنة الصبح عشان انقاص الوزن. دكتور بريشيل قالت انه شيء سيء جدا يجب ان احنا نتجنبه تماما. كمان خل التفاح من اشهر الحاجات اللي بتتاخد عشان نقصان الوزن. هي خل التفاح هو يعني حمض ستريت حمض، يعني ما فيه، يعني هيعمل مشاكل كبيره جدا للناس اللي عندها بتعاني من قرحه المعده والاثنى عشر. فكل السيدات اللي بتتناول خل التفاح بكميات كبيره من اجل انقاص الوزن عليها انها تتوقف تماما. لو عندك مشكله في فكره زياده الحموضه او قرحه في المعده والاثنى عشر، كل ده بيعمل مشاكل كبيره جدا. زي ما انا قلت جالي سؤال كمان من مينا بيتكلم على العلاج بالكورتيزون. زي ما قلنا مينا هو البخاخات بس، البخاخات ملهاش علاقه بفكره القرح، ولكن الحاجات اللي بتتاخد بالبق هي اللي بيبقى فيها مشاكل كبيره جدا. So Dr. Prechel, the symptoms, what would I feel if I have an ulcer and why it's overlapping with so many diseases we discussed?
When you peptic ulcer disease is associated with epigastric pain, and we're talking, when we say epigastric pain, we're talking in like the mid-chest area. And when we walk through the day, we're upright, so it has a propensity. It's easier, you know, gravity takes our food down, the acid, better digestion.
Yeah.
And a lot of times you'll see the symptoms are exacerbated or increased at night because when you're laying flat, they're just sitting there. They're sitting in, like I said, like that curvature. That little baby cuddled in your stomach, they're just sitting there in the lining of the stomach.
Okay.
And so you start getting like that acid burning. It's on fire and it's cooking and it wakes you up at night.
The first symptom is epigastric pain and heartburn.
Yes.
Okay.
And sometimes people even confuse it with having a heart attack. The pain can be so intense that it feels like a heart attack. And all of us at some point have experience some type of epigastric pain.
Okay.
And some of the symptoms that creates where we feel nauseated, because you get, the stomach is a muscle, so it causes an inflammation in the stomach. And then we can get a lot of burping. It's like irritated. That muscle of the stomach is irritated and contracting. We get a lot of burping. We feel bloated because the stomach, it gets inflamed at that time.
Okay.
And then we refer to that as like the heartburn, the chest discomfort.
Okay. What else of the symptoms that we might experience with those stuff?
You can also get, and as it gets more severe, you can get vomiting. You get that dyspepsia. Dyspepsia is that burning sensation that you feel.
Okay.
And it can even lead to the point when you have that pain, you don't want to eat, because when you eat, it exacerbates that pain. It increases that pain.
So it's a psychological element,
right.
Like psychological pairing. You don't want to eat, so you don't get hurt.
You don't want to eat, so then that leads to weight loss. You know, you're taking less food, and in the more severe cases, because it is an ulceration, you are eating up that inner lining of the stomach, that you can get hematemesis, it was just where you get blood-tinged vomit when you're vomiting. And then as it prolongs over longer periods of time, you're digesting that blood. And as it transits the entire digestive tract, it gets dark. It becomes dark and the stools become dark, and it's called melena.
So when the stool gets dark, that's an alarming symptom that you really need to consult with your
Right, because then that means it's long-term.
Okay.
It's a long-term condition.
Okay. What about the ulcer that comes from the NSAIDs, the non-steroidal anti-inflammatory?
With NSAIDs, because it's usually more of a chronic condition, you're taking them repeatedly, you know, for a longer period of time, they consider it like a silent cause.
Okay.
That it's there and you don't feel it as quickly because it's more of a chronic condition. It's happening over time.
So you can get it in the worst form ever after it gets perforated. Or
Right, then it leads to the bleeding because it's eating its way through. As we talked about earlier, you have those 3 layers. That when you, the inner mucosa, then the sub mucosa, and then if it totally perforates the stomach, then you get in through the muscular layer of the stomach and you have a hole basically in your stomach.
Okay. هي سؤالي لدكتور برشيل كان عن ايه هي الاعراض اللي بيحس بيها مريض اللي عنده قرحه في الاثنى عشر او في المعده. قالت لي رقم 1 الالم اللي بيجي بشكل شديد جدا اللي احنا بنسميه الالم في فم المعده اللي بيبقى في الصدر كده من تحت شويه، بيبقى الم فظيع جدا. الحاجه الثانيه حرقان، بتحس انه صدرك بيحرقك يعني زي ما بنقول. الحاجه الثالثه انه طبعا الهضم بشكل عام ما بيبقاش كويس، احيانا الناس بتشعر بانتفاخ وبالذات مع الاكلات اللي فيها دهون كتيره جدا. الحقيقه قد تصل الى حد انه الشخص ده بيبقى فيه غممان نفس طول الوقت. كمان ده بيؤدي الى انه ممكن يبقى فيه ترجيع شديد جدا. حاجه تانية مهمه جدا قالتها دكتور برشيل انه احيانا مع الترجيع ده نتيجه البليدنج اللي بيحصل او النزيف اللي بيحصل من القرحه دي، انه احيانا الناس بنلاقيها بترجع دم احيانا، او بنلاقي الترجيع بتاعها زي ما بنقول كده في خيوط او فيها دم. فده مهم، دي ساين مهمه جدا ان حضرتك لازم تروح للدكتور بتاعك وتعمل يعني تشوفه وتناقش معاه المشكله دي. كمان حاجه مهمه جدا انه احيانا لما القرحه بتبقى لفتره طويله جدا بنلاحظ انه لون البراز غامق جدا نتيجه برضو النزيف اللي بيحصل من القرحه دي، وعلى طبعا ما بيدخل في كل الجهاز يعني بيمشي في كل الجهاز الهضمي لونه بيغمق جدا وبيخلي البراز شكله غامق جدا. مهم جدا، ساين مهمه جدا، اذا لون البراز اتغير للون غامق زي ما بنسميه بيبقى لونه اسود، مهم جدا انه دي تبقى ساين بالنسبه لحضرتك او لحضرتك انه تستشير الطبيب بتاعك. نقطه تانية مهمه جدا عايز اقولها انه قرحه المعده والاثنى عشر اللي بتيجي نتيجه استخدام المسكنات، واللي تاني هقعد اقولهم كل شويه، الادفل او الايبيبروفين او البروفين او الاليف، كل ده القرحه اللي بتيجي نتيجه الكلام ده ما بتبانش غير لما بيحصل عندها مشاكل كبيره جدا. فبرجو تاني من حضراتكم ان احنا نتوقف ان احنا كل شويه نقعد نبلبع حبوب لو احنا مش محتاجينها، لانه بيبقى ليها قد يكون ليها اثار كبيره جدا وتسبب لنا مشاكل كبيره جدا. Dr. Shams, does the pain from duodenal ulcer different from the gastric ulcer in general, and what are the alarming symptoms and signs that worries you as a physician?
Yeah, there is a difference between them, and the audience need to know that usually duodenal ulcer occurs about 1 to 3 hours after you eat food. And it's pretty common sense, and if you think about the anatomy again, as I said, you have the stomach, the whole stomach, that food gets in there, and it passes through to duodenum. So it takes about 1 to 3 hours. So as it gets to, for the duodenal ulcer, it takes about 1 to 3 hours after you eat, and it potentially awaken people from the sleep. The pain is very intense, and it hurts, so it wake people up. People who eat and they tend to go to bed, waking up a couple hours later, you can, more than likely it's duodenal ulcer. And usually the pain gets better when you eat something because it dilutes it, and so the acid doesn't get to the duodenum.
But we can get that picture in slide 5 if you want to explain it more on a picture.
On the picture, that would be good actually. Yes, I'd like to show that picture.
If we get
picture
slide 5.
Yeah, so when you see the stomach, when it's when it's in the stomach area, the pain exacerbates when you eat because the ulcer is in there, right in the stomach area, and
so it gets worse with
it's
food.
worse with food, yes, as opposed to duodenum, which is that the end of the stomach
to the left side, the end of
exactly, that's the duodenum. It takes about 1 to 3 hours. That's what I was talking about, the food getting into that tube, and it caused the ulcer. Basically, the food, when you eat it, it subsides the pain.
And what are the alarm symptoms and signs that worries you as a physician?
I think that is really important, and they really need, the audience need to take action, is if you start throwing up blood.
Okay.
That is very alarming, and that's a GI bleed.
Okay.
And any kind of bleeding is not normal. So be it from up or the bottom, they need to see a doctor, go to emergency room. immediately.
Right away.
So GI bleed is important, that's acutely. But if you have over a long period of time, you don't have to throw up blood. It's, as I said, if the ulcer is small enough and slowly trickle, and as Dr. Prechel said, it goes through the intestine and goes, that's a chronic, over long time bleeding. And that's important. They need to know. And how would you know? Well, you do blood tests if you're anemic, iron deficiency, because you need iron to build red blood cell. And if you don't have that, so you
or
need
if
to
you have any like symptoms of anemia, if patient can recognize it, like rapid heart rate,
well, yeah,
fatigue,
anemia,
dizziness.
right. You need to have, that's what I do with my patient, annually, at least annually or every 6 months, blood test to see if the red blood cell goes up or down. But at home, if you see you're getting more tired, fatigue, short of breath, you don't have enough energy, you look very pale. These are...
your heart is racing sometimes.
Heart is very racing. These are all the symptoms of anemia that your body is communicating with you. Seek help. So it's important. Other things, if you just, whatever you eat, you keep throwing up. You throw up, and persistent vomiting. Not a good sign. You need to see the doctor. And most importantly, as Dr. Prechel was saying, if you have pain, mid-epigastric around the lower the breast cage, you have pain, that is important. You need to find out why you have that. And if you have patient age 55 years and older,
and losing weight, for example.
They're losing weight. It's a very, they have the pain in the middle of the chest, and they're losing weight. This is your body communicating with you that you need to go see a doctor. It's important.
Okay. الحقيقة لو رجعنا لسلايد 5 عشان نوري حضراتكم واحنا بنتكلم ايه هي قرحة المعدة، قرحة الاثنى عشر، أماكن تواجدهم. الباوتش الكبير اللي قدام حضراتكم على الشمال ده هو المعدة اللي احنا بنتكلم فيها، والتيوب التيوب اللي على الشمال دي بالظبط كده اللي عليها البوينتر هي دي الاثنى عشر. فزي ما احنا شايفين قرحة المعدة دي قرحة اللي هي عليها البوينتر، دي قرحة الاثنى عشر. اللي على اليمين شوية دي بتبقى قرحة المعدة بالظبط كده. حاجة تانية مهمة سألتها الدكتور شمس، ايه هو الفرق في الألم؟ يعني زي ما قال الدكتور بريشيل انه دايما بنحس بألم، دايما بنحس بحرقان في فم المعدة، الحاجات دي كلها. ايه الفرق بين الصورتين؟ احيانا قال لي بيبقى الفرق انه دايما قرحة المعدة بتبقى أسوأ بكتير، الألم بيبقى أسوأ بكتير جدا مع الأكل. قرحة الاثنى عشر الألم بيتحسن مع الأكل، وده فرق كبير ما بينهم. الناس ممكن يعني تاخد بالها منهم. سألته كمان ايه الحاجات، ايه الأعراض اللي لما تحصل بتقلقك انت كدكتور؟ قال لي رقم واحد انه البيشنت زي ما احنا قلنا انه يبتدي يرجع دم، او يبقى الترجيع بتاعه فيه جزء من او معرق دم زي يعني ما بنقول، ده بيقلقه جدا. الحاجة التانية انه يبتدي البيشنت ده من البليدنج او من النزيف يحصل له نوع من الانيميا، ده برضو بتبقى من الحاجات المقلقة جدا بالنسبة له. انه يحصل فقدان للوزن غير مقصود تماما من البيشنت يبتدي يفقد وزنه، لانه طبعا الاكل بيعمل له الم شديد جدا، وبالتالي بيمتنع عن الاكل كناحيه نفسيه. فده برضو فقدان الوزن الكتير الغير مقصود من البيشنت برضو من الحاجات اللي بتقلقه جدا. كمان الترجيع المستمر ده برضو من العلامات اللي بتقلق اي طبيب بيعالج مريض عنده قرحه معده او اثنى عشر. كمان المرضى اللي فوق 55 سنه زي ما احنا قلنا بيحصل لهم نوع من الانيميا المفاجئ، او بيفقدوا وزن بشكل كبير جدا وهم مش قاصدين يعملوا ده. دي من الاعراض اللي بتقلق جدا. هناخد بريك، نرجع مع حضراتكم نتكلم على فكره. احنا كده اتكلمنا على الاعراض، اتكلمنا على ايه هي القرحه. هنرجع نتكلم مع حضراتكم ازاي نشخص ده، والبكتيريا اللي عامله لنا مشكله في فكره القرحه، ويعني فكره قرحه المعده والاثنى عشر اللي هي الهيليكوباكتر بايلوري، هنشخصها ازاي نتجنب المشاكل اللي بتحصل من ده. وكمان مش بس التشخيص، هنتكلم مع حضراتكم على العلاج وايه هي الحاجات اللي ناخدها، ايه الحاجات اللي نتجنبها. كل ده هنناقشه في الجزء الاخير من حلقتنا. هناخد بريك ونرجع نتكلم مع حضراتكم في التشخيص والعلاج.
Are you tired of being overweight? Do you suffer from diabetes? Do you suffer from hypertension? Do you suffer from obstructive sleep apnea? Do you suffer from hypercholesterolemia? Have you suffered from heart attacks in the past? Strokes in the past? Are you tired of being ostracized in public? Well, I have a solution for you. Robotic bariatric surgery. This can completely change your life. I'm Dr. Bobby Baskerau. I'm a robotic bariatric surgeon. I do robotic weight loss surgery, which can completely change your life. I offer 3 different types of surgeries that can completely change your life. The sleeve gastrectomy, the lap band, and the Roux-en-Y gastric bypass. One thing that's very unique about our program is that we have a dietitian, and you will get counseled on what to eat, what not to eat, and how to optimize the utilization of your tool for good weight loss.
اهلا بحضراتكم مع الجزء الاخير النهارده من حلقتنا. كل الاسئله اللي جات لنا انا لاحظت ان احنا يا اما جاوبناها اثناء يعني في الاسئله او هنجاوبها في العلاج، ما عدا يعني الاسئله اللي مختلفه شويه اللي هتبقى يعني مش متضمنه في الاسئله بتاعتنا بتاع الحلقه. هحاول اخدها واحد ورا التاني. زي ما حضراتكم عارفين تقدروا تبعتوا لنا كل اسئلتكم على صفحتنا الرئيسيه على الفيسبوك وايت كوت كرمة تي في، وهنحاول نجاوب معظمها لحضراتكم. So we talked about the symptoms and the disease and the prevalence and all those stuff. Now let's get in business. How we diagnose.
Okay, so now your symptoms have become chronic, and your NSAIDs aren't, and your Tums aren't helping anymore. So now you're into seeing me. So
yeah, like basically I start seeing you after I'm getting tired of medicating myself. So I need to see a doctor. Right. So I need to see a doctor now. Right.
Yeah. So usually we start with the least invasive testing. So we'll check for blood in the stool. We'll do a stool sample. We send it out. We test for the blood in the stool. And then we'll do the basic lab test where Dr. Shams was talking about. You're going to check for anemia. And we'll do a basic CBC where it checks for the hemoglobin. Okay. And usually you'll see drops in hemoglobin if there's blood loss.
Because of the bleeding.
Right. And then you can do liver function tests and amylase lipase, because as you get into perforation, the pancreas and the liver can get perforated because they're lying back there behind the stomach. Right. So then you would test for their
functions.
Yeah, their functions. Okay. And then we test for H pylori.
Okay.
So there are a couple ways that we can test for that.
Yeah, I'm going to stop you here because we need to explain it like in detail. So what we do for H pylori, because that's the main problem, this little bacteria that we're talking about.
Okay, so for H pylori, they have the test where it's the breath test. And it's a 2-part test where you breathe into like a balloon type machine. Okay. And you do like a pre-test where you just normally breathe into the apparatus, and then you're given a solution that you drink. And that solution, if the nitro is in the system, it breaks it down, and then when you breathe it out the second time, it goes into that second tube. Okay. And it's a carbon dioxide. There's like a carbon dioxide 13 and 12 to be technical. And you're looking for high levels of that carbon 13 in that breath. Okay. And if that is high, it's positive for H pylori in the breath test.
So number 1, still the stool occult blood.
Yep.
Number 2 is we do CBC and liver function test, pancreatic function test as well. And then we do the breath test. Is it accurate, or who would be a good candidate for it?
It's very accurate. Okay. You know, in younger patients probably, because you don't want it. The next step obviously is invasive testing. Okay. And so that you do more on younger patients that don't want to have invasive testing.
So we go after the breath test to what?
Then we go to where you're going to do a upper GI, an EGD, where they put a microscopic tube and they go and they get visual camera, and then you have the absolute visualization of the stomach and the duodenum. So it's visualized during that camera. Okay. And then they do biopsy. They take a biopsy of the stomach mucosa, and
the ulcer itself.
The ulcer itself, if it's visualized.
Okay.
And then they test it with the urease test, and it tests if the H. pylori bacteria is in that mucosa.
Do you have a preference as a physician for any of those tests, or you just go from the less invasive to the most invasive?
You know, most patients, by the time they come see me, honestly, are already ready for EGD.
Okay.
They're ready for invasive testing.
Okay.
Otherwise,
So
they wouldn't be there.
let's take pictures and get in business, right?
Yep.
Okay.
Because then you know.
Okay. So
Because EGD is actually the #1 gold standard diagnostic test
okay,
for
and
accuracy.
we can take a specimen to analyze it. Too,
Right. So you know absolute.
اوكي. الحقيقه سؤالي دكتور برشيل كان عن ازاي نشخص يعني المرضى اللي عندهم قرحه في المعده او الاثنى عشر، ازاي نشخصهم. قالت لي رقم واحد بنعمل شويه يعني تحاليل او انفستيجيشنز يعني عشان نشوف ايه المشكله. رقم واحد بنعمل حاجه اسمها ستول فيكال اوكلت بلاد، انه زي كارت كده وبناخد عينه من البراز. وهي الفكره بتاعت ده كله ان احنا بنشوف هل في دم، هل في نزيف في البراز ولا لا، في بليدنج ولا لا. اذا طلع ايوه بنروح للتست اللي بعده، بنعمل حاجه بنعمل كمان صوره دم كامله عشان نشوف هل النزيف ده ادى لاي نوع من الانيميا في البيشنتس ولا لا. كمان الاشهر بقى والتست الاشهر اللي احنا بنتكلم عليه البكتيريا اللي هي الهيليكوباكتر بايلوري. والحقيقه انا في 3 من مشاهدينا بعتين لي الانفستيجيشنز اللي حصلت بتاع الهيليكوباكتر بايلوري دي، وهيبقى جزء كبير من الاجابه موجوده في الخطوات الجايه. فرقم واحد عشان نكشف على الهيليكوباكتر بايلوري دي ان احنا بنعمل حاجه اسمها اختبار للتنفس. وهو الفكره كلها انه البكتيريا دي بتنتج ماده، الماده دي احنا بتطلع في النفس بتاعنا، فبنحاول اذا لقينا الماده دي معنى كده انه البكتيريا دي موجوده واكتف وشغاله. فده مهم جدا ان احنا بنعمل تيست النفس ده. لو طلع بوزيتيف يبقى البيشنت ده بيعاني من البكتيريا اللي هي الهيليكوباكتر بايلوري، بنبتدي نعالج. انما عشان يعني اكتر وسيله دقيقه هي فكره المنظار، ان احنا بنعمل منظار للمعده وللاثنى عشر. وكمان المنظار ده بيمكننا ان احنا نشوف القرحه بعينينا، مش بس ان احنا نشتغل على البكتيريا، لانه زي ما احنا قلنا انه القرحه دي ممكن يبقى ليها مسببات غير البكتيريا اللي هي الهيليكوباكتر بايلوري او الاتش بايلوري زي ما بنسميها. فالمنظار هو زي ما قال الدكتور بريشيل دي اقوى حاجه بتخلينا نشوف القرحه، وكمان ناخد منها عينه لألا تكون القرحه دي قد تحولت لنوع من انواع الكانسر. فمهم جدا ان احنا المنظار ده بيبقى وسيله مهمه جدا لتشخيص المريض. زي ما قلنا مع حضراتكم فكرة التست الأولاني بتاع إذا في نزيف ولا لأ في البراز. الحاجة التانية صورة الدم الكاملة. الحاجة التالتة اللي هو التست بتاع التنفس، وده بيبقى متواجد في العيادات، مش لازم تروح يعني تعمله في حتة معينة. الحاجة الرابعة والأخيرة المنظار، لأنه المنظار ده بيبقى تشخيصي بشكل كبير، وزي ما قلت بنقدر ناخد عينة من القرحة دي نشوف إذا تحولت لكانسر ولا لأ. We diagnosed finally. Let's get in business. What you're doing every day for life. How would you treat your patients? Would we start with medications, or do you give them some advices first?
Yeah, I believe in holistic. You know, when you need medication, you need medication. That's fine. But I like to discuss and talk to my patient. Tell them, you know what, as I said before, what the cause of it, non-steroidal anti-inflammatory. So, but they said, what about if I have headache? You know, if you discontinue Motrin, Advil, you can always take Tylenol. Tylenol doesn't affect the lining of the stomach.
So you're teaching us today Tylenol is safer.
Tylenol is safer. Okay, let's back up a little bit.
Okay.
Everything you put in the mouth have a side effect.
Okay.
So I want everybody to know that whatever you put in your mouth, whatever medication you're taking, everything have side effect. You have to choose which one that you want to take. Now, Tylenol in excess will damage the liver. So I don't want people to think Tylenol is a safe drug and take as much as possible. No, everything moderation. If you're a couple of Tylenol here and there a day, it's fine. It's not going to upset your stomach. Things like, again, Advil and Tylenol, those are the ones that you should stay away as much as possible for ulcer.
I have a question here. He's 68 years old, and his doctor prescribed aspirin for him every day. So he's asking you, does it affect, because we mentioned the ibuprofen and Tylenol, but we didn't mention aspirin. So does aspirin affect for just to prevent clotting and stuff?
I'm very happy that the audience brought this up. Yes, the aspirin does cause problem with the stomach, and it causes ulcer also. But I'm sure the doctor give him aspirin is probably because of the heart protection, or
right.
And usually the dosage is very small. It's called a baby aspirin. It's only 81 milligram. And if you take that with food, it does not have as much effect as taking like a lot of Motrin, or people tend to overdo on aspirin.
Okay.
You know, I have a headache, they take 325 milligram of aspirin 2-3 times a day. That will eat through your stomach.
Okay.
That's what Dr. Prechel was saying, basically causing the hole and bleeding. So to answer the audience, taking one aspirin, baby aspirin, 81 milligram, is okay. And with food, and they should definitely take it because that is protecting the heart and stroke. So
okay.
Absolutely.
Okay. So what else? Go ahead.
I just wanted to say one thing. Like everything, you have to consider benefit and risk.
Okay.
You know, like Dr. Shams said, anything you put in your mouth has some risk.
So cost-benefit
right.
ratio.
Even food.
Yeah.
Foods are contaminated.
Right.
You know, so everything is, you know, risk-benefit. So you just have certain steps that you have to take to limit those risks. Like
okay.
even with any of the ANSAIDs, the Advil, the Aleve, the patients that have to take prednisone for their breathing, you know, doctors always recommend that you take it with food, so that gives the stomach some protection when that food is going down. I mean, when the medications are going down.
So everything is a cost-benefit
right.
ratio. Okay. What else in the non-pharmacological part?
Yeah, and acid suppression, how do you decrease the acid in the stomach? So you take things like Mylanta, Maalox. Tums is a really good choice. If somebody, for pregnant women, I always say, if you need to suppress the acid, Tums actually is a good choice, calcium for you. So that the other area, is we alluded before, is smoking. Smoking is extremely important. You can cut back on your smoking and totally stop it, because that's aggravate the acid. And we go to the spices, eating, you know, food that you eat. Limit your spices, limit the acidity of the food.
Caffeine. Caffeine.
Oh yeah, caffeine, yes, absolutely, caffeine consumption.
What about chocolate?
Chocolate does have caffeine in it, okay. So that's, again, I want my patient to know that, you know, I'm very much quality over quantity. So you should, if you want chocolate here and there, it's okay, but don't sit down and eat 5-6 boxes of chocolates a day. No, that's not good. So limit that. Even we go to alcohol, as I said before. Alcohol is one of the aggravating factors for the ulcer. So limit that. In the men under the age of 65, I mean, you can have about 2 drinks a day is okay. You can have that. But once you get above 65, again, because of the lining getting thinner, you need to cut back. So maybe 1 glass a day. And most importantly, at the end, stress reduction is very important.
Okay.
Meditation is very important.
Okay. Prayers. A lot of
Prayer
prayers.
is more important, yes.
Dr. Prechel, what about medication? That's the non-medication
Right, so
part.
now after all the lifestyle changes and they're not working, then we get into treatment plan.
Okay.
Okay, once you've been diagnosed with H. pylori, it's medication.
Okay.
And it's treated with triple therapy with proton pump inhibitors, and there are several on the market today.
Okay.
And
when we say triple therapy, that means 3 medications together.
Yes.
Okay.
That we're using antibiotics and proton pump inhibitors that work on the acid production.
Okay. Is there any preferred antibiotics to start with?
Yes. So usually what was initially used was, it's called clarithromycin and amoxicillin with a proton pump inhibitor. That's also called Biaxin.
Okay.
And then there are several choices today that we have to choose from when we're talking about proton pump inhibitors. The one everybody's familiar with is the purple pill,
right.
Nexium.
Nexium.
Everybody knows that one from
right.
TV commercials. But then there's also omeprazole, Prilosec, which is over the counter now, Prevacid, Lansoprazole,
Acifex too as well.
Acifex, and then we get into the antibiotics. So you're taking those proton pump inhibitors twice a day for 14 days. They're at an extended doses.
Okay. What happens after the 14 days? Do you...
After the 14 days, we usually wait a week in between, and then you retest the patient for the H. pylori to assure that we have total eradication or removal of H. pylori, that the bacteria is gone from the stomach lining.
Okay. What happened in both cases? If it's gone, do they need to stay on something? And if it's not gone, what's...
If it's gone, we usually keep them on it for 2 weeks, extended period of time.
Okay.
And then if it's showing that it's still positive, they can retreat with just a normal regular 14-day course, or they can do an extended course.
Okay.
Sometimes they do it for 3 weeks.
Okay. So I have a question here. 27 years old lady, she's pregnant, and she's asking if it's safe to take those kind of antibiotics and treatments.
Usually when you're talking about pregnancy, it's usually up to your OB, but you've had it for quite a long time already.
So
I would
make
wait,
it through, push it
make
through.
it through those 9 months of pregnancy, because you don't want to add any complications, and there's always a worry, you know, with any medication. So we always try to wait till after therapy.
Okay.
I mean, after pregnancy, and then start therapy.
And of course, consult with the OB/GYN.
Yeah, and everything is always
Safer.
up to your OB.
Okay.
Yeah, but they can, the symptoms, if they have, I don't want them
Yeah,
to
you
be in
can
pain
take
either.
Tums.
You can, Tums is really good, as I said, with pregnancy. Even if they don't have pain, I have seen my OB/GYN encouraging the patient to take Tums.
Even my Lantus.
Take them.
Okay. So that's if the reason is H. pylori. What if the reason of the ulcer is non-H. pylori one, like all the other causes and risk factors that we talked about?
So if you have non-H. pylori, then we don't use antibiotic treatment in there. But we still use the proton pump inhibitor, which are, like we talked about, the Nexium, the Asifex, Protonics, or we use H2 blockers. And
Okay.
H2 stands for, the acid in the stomach is hydrogen, so it's the H. And we use those for up to 8 weeks, the H2 receptor blockers.
Can we give some examples?
One of the oldest ones that's known is cimetidine or Tagamet,
Okay.
but we don't use that one so much today because there are a lot of side effects and a lot of drug-drug interactions, especially with cardiac medications.
Okay.
So we don't use that too much, but we use Pepcid and Axid and Zantac. Those are the common ones used today.
Okay. So they just stay on those for 4 to 8
4 to
weeks?
8 weeks of treatment.
If the reason is not H. pylori.
Right. It's just you're treating symptomatically now.
Okay. As you guys mentioned, now everything has side effects. So what's the side effects for long-term use of antacids in general?
Antacid, you know, when the proton pump inhibitor came out, at the beginning was excellent, very good, and it is still a good drug, but we tend to overdo it. If long term when you use it, proton pump have been shown it causes other infection, like infection called Clostridium difficile, C. difficile, which is in the colon, and it causes a lot of
So it
diarrhea.
affects the colon.
Affects the colon.
In the long term.
Affects the long term, exactly. You do need all these things that you have in your body. There's a purpose for it.
Okay.
God gave this thing for a purpose. So you do need acid. What do you need acid? To break down the food and absorption. So if you have, it causes proton pump inhibitor, which is inhibit secretion of acid. It causes hypomagnesemia. You don't absorb enough magnesium. It causes malabsorption in calcium, and you know calcium is really important for bone mineral, and you get osteoporosis, fractured, and these are the side effects, you know, absorption.
When you say hypomagnesemia, that's a little bit of a medical term. So what does the patient feel if the magnesium is low?
Well, magnesium, the effect of magnesium works mostly in the heart. The heart, like calcium works for the bone, magnesium is for the heart, so you get irregularity. Heart, there's a lot of problem with the heart, you know, palpitation, and these are all the sign of
body aches, muscle aches.
Body ache, muscle ache, we call it Charlie horse, leg pain, and all these are low magnesium.
Okay.
So you need to, these are the, again, your body is talking to you.
So it affects the colon movement, it affects the calcium and the magnesium in the body. What else?
Magnesium, and another thing is very important is you need vitamin B12 to produce the red blood cell.
Okay.
And you have deficiency because the absorption of B12 goes down. So again, related to the anemia, not only bleeding, but absorption too. So And last but not least is cause a lot of basically diarrhea, gases, bloating, and so these are all the side effects of using all these antacid over a long period of time.
Okay. الحقيقة هنا هتبقى يعني شوية حضراتكم بقى تركزوا معايا في النقطة دي، لأنه هي العلاج بتاع الموضوع. أي المرضى اللي بيعانوا من قرحة المعدة والاثنى عشر، إذا كان السبب فيها هو الهيليكوباكتر بايلوري أو الاتش بايلوري زي ما بنسميها، عملنا التست ده وطلع بوزيتيف، أو عملنا المنظار وطلع بوزيتيف. والحقيقة أنا عندي يعني 3 من المشاهدين بعتني الحالات بتاعتهم إنه طلع الاتش بايلوري دي بوزيتيف. فمهم جدا ان احنا البيشنتس دول يتحطوا على نوعين مختلفين من الانتي بايوتيك، يعني واحد فيه اموكسيسيلين وكلاريثرومايسين اللي هو اللي بنسميه البايكسين. كمان بيتحطوا على نوع من مضادات الحموضه، اشهرهم على الاطلاق اللي هو الاوميبرازول، البريلوساك ده موجود اوفر ذا كاونتر. كمان البريفيسيد او اللانسوبرازول. الاشهر حاجه معروفه عند كل الناس هو النيكسيوم. النيكسيوم اللي هي الحبايه البيربل دي بتبقى مشهوره عند كل الناس. فالبيشنت اللي عندهم الاتش بايلوري بوزيتيف بيتحطوا على نوعين انتي بايوتيك، وبنحطهم على واحد من مضادات الحموضه اللي ذكرناها لحضراتكم، وبعدين بنعمل التست تاني بعد 14 يوم او بعد اسبوعين. يفضل ان احنا نمدها شويه ل3 اسابيع. اذا طلع تاني الاتش بايلوري لسه موجوده، بنعيد نفس الكورس مره كمان، بحيث انه يبقى اسبوعين كمان. وبرضو بنفضل ناخد فكرة مضادات الحموضة بتكمل معانا على طول. لو الاتش بايلوري دي طلعت نيجاتيف، ولكن البيشنت او المريض مازال عنده قرحة في المعدة لنتيجة تانية غير فكرة البكتيريا بتاع الاتش بايلوري، بنحطه على مضادات حموضة اللي اتفقنا عليها، اللي هو البريفيسيد او البريلوساك او النيكسيوم. كل ده مهم جدا. وفي انواع تانية من مضادات الحموضة اللي هي برضو موجودة اوفر ذا كاونتر، اللي هي البيبسيد او الزانتاك، اشهرهم على الاطلاق، والاثنين موجودين اوفر ذا كاونتر. بنحط البيشنت عليهم من 4 ل8 اسابيع، لانه ده مهم جدا. برضو اسئله كتيره جايه على فكره ايه هي الاعراض الجانبيه للادويه دي. زي ما قال دكتور شمس، بتاثر على الحركه بتاع القولون بشكل عام، فبتعمل احيانا انتفاخات. بتاثر على المغنيسيوم في الجسم، ولما المغنيسيوم يقل بيأثر على ضربات القلب، بيأثر على العضلات بشكل عام، بنحس بألم في العضلات بشكل عام. كمان بيأثر على امتصاص الكالسيوم، وده مهم جدا. لو احنا فضلنا ناخد مضادات للحموضة لفترة طويلة جدا، بيأثر على امتصاص الكالسيوم وبيعمل نوع من هشاشة العظام. بيأثر كمان على حاجة مهمة اللي هو فيتامين بي 12 أو ب 12، وده اللي بيعمل الإحساس بالتنميل بشكل عام في الجسم، لأنه بيسبب كمان نوع من أنواع الأنيميا. فاستخدام مضادات الحموضة على فترات طويلة، ان احنا نقعد ناخدها سنين، هقول تاني بيأثر على القولون احيانا بيأثر على نسبة المغنيسيوم في الجسم، بيأثر على فيتامين بي 12، بيأثر كمان على امتصاص الكالسيوم، وده بيبقى شيء مهم جدا للسيدات لانه قد يؤدي الى هشاشة عظام، وده مهم جدا. Dr. Meshel, is it preventable? Like, can we prevent it sometimes? Can we be on some medication to prevent the infection?
Yes, and from the damages of certain medications that certain people just must be on. Like we talked about patients that have arthritis or patients with rheumatoid, you know, or back injuries, they have to be on, you know, some type of pain medication. And mostly we use non-steroidals, the Aleve, the Motrin, patient with chronic headaches. So in order to prevent these ulcers from occurring, that we can give them medication with the proton pump inhibitors. So we give them ahead of time. Patients that are on aspirin, you know, as we use them cardioprotective these days, or patients that are anticoagulants if they have atrial fibrillation or just simple the baby aspirin, we put them on the proton pump inhibitors or the H2 blockers, or now with the NSAIDs, there's the prostaglandin is what they affect in the stomach lining, the element in the stomach. So that's called misoprostol or cytotec. And so we put them on it initially, knowing that these patients have to be on these medications, so we treat accordingly to prevent them.
Okay, let's say I have H. pylori and came back positive and you treated me. What about the recurrence rate?
Recurrence rate, isn't usual in a lot of patients, but it does happen. You'll have patients that are resistant to the first treatment, and then we usually treat everyone again because we want to make sure that they're eradicated. So we'll wait at least 4 weeks, do breath test, or they can test a stool antigen, and we need to wait at least 8 weeks because you want to make sure you give the medicine enough time to work and that we don't get false negatives.
So it can happen again?
It can happen again.
Okay.
And you can have periods also where you are negative, but you continue on with the same lifestyle. You know, like Middle Eastern people, the way that they... Cultural with the foods. They eat a lot of raw meats, and it's very common, you know, with raw meats that the bacteria is there and they can get treated and reinfected.
For both, what if it's resistant? Like it kept happening again and I get treated and I get it again. Do we have like a solution for this or just keep getting treated?
This Helicobacter is actually an interesting bug. It looks like a corkscrew, and it basically screws itself in the stomach mucosa, and it's a very extremely tough, hard bug to kill.
Okay.
And usually we treat them, as Dr. Prechel said, I treat them the first line, the recommendation, and a couple of weeks, 14 days, and if tests come back positive again, we have to go one step up to quadruple for different medication. And again, most of the time that does work, but those very small population that these bugs are resistant to, if we test them and can come back positive, then you have to go to a higher top gun like INH, and that's...
So you use bigger guns then.
Bigger.
Okay. الحقيقة سؤالي دكتور بريشيل كان عن ايه هي نسبة انها ترجع تاني بشكل عام ال H Pylori لما بتتعالج. قالت لي انه في يعني نسبة انها ترجع تاني حتى لو بعد ما اتعالجت بناخد تقريبا نفس العلاج. سألتها طب بالتريتمنت، دكتور شمس قال ان احنا بدل ما بناخد 2 مضاد حيوي و1 مضاد للحموضة بنضيف لهم حاجة اللي هو علاج رباعي يعني زي ما بنسميه، بنضيف لهم حاجة رابعة كمان. نقطة مهمة جدا انه البيشنتس اللي عندهم كرونيك بين او الام مزمنة في الجسم وبتتطلب ان هم يبقوا على نسبة من الايبيبروفين، مهم جدا ان احنا برضو بياخدوا نفس العلاج كنوع من الحماية للكلام ده كله، لانه زي ما احنا قلنا انه الادوية دي بشكل عام بتسبب قرح معدة بشكل كبير جدا. So the complications expected and how we deal with it.
Yeah, it's again, it's important. One of the things with the Helicobacter pylori that I want everybody to know about it is it causes different stages, and it's over a period of time with basically gastritis, irritation, tend to in the ulcer become basically perforated. And once that the perforation, which is not that often, hopefully we catch it early, is about 7%, and it goes, stomach sits on top of the pancreas, so perforated, it can go to pancreas, cause pancreatitis, secrete into the liver, cause liver problem, or inside the abdomen.
So perforation is number one complication.
Number one, it's a very, it's a serious thing. It's a serious thing that need to be addressed fast.
Okay.
Then it causes, if the bug, if it gets perforated, get a hole in the stomach inside and goes into the abdominal cavity, we call it peritonitis because there is bugs in there. So infection, it's a sterile environment in there, and the bug goes, we call it peritonitis, which is very important and dangerous too. That by having the tumor, it causes bowel obstruction. You can have bowel obstruction. And if the tumor is big enough, as the picture, if you remember, the stomach goes to the small intestine, that area, it can block it, it can obstruct it.
A lot of questions here asking about the cancer transformation for...
And that is the number one. That was, they got the Nobel Prize for it because the Helicobacter pylori is a direct relationship to having a cancer.
For gastric cancer?
Gastric cancer, correct. Gastric cancer, it's very important.
Okay. هي سألت دكتور شمس لو سيبنا القرح دي أحيانا من غير ما تتعالج، أو زي ما بقول طبقا لثقافتنا بنقعد نشرب لبن وناخد مضادات للحموضة، قال لي رقم واحد إنه ممكن فعلا المعدة الجدار بتاعها يتخرم، وبالتالي بيعمل مشاكل مش بس في المعدة كمان في البنكرياس، والمفروض إن احنا لما نبتدي نحس بالأعراض دي نسأل نصيحة طبية على طول، ما نستناش لحد ما ده يحصل. الحاجة التانية النزيف اللي بيحصل، لأنه طبعا وجود قرحة في المعدة بتعمل نزيف بشكل عام في الجهاز الهضمي، وتقريبا 1 من كل 3 من مرضى القرح بنسبة 33%، 1 من كل 3 بيعاني من أمراض النزيف. فالنزيف وزي ما أنا قلت لحضراتكم إنه ممكن جدار المعدة نفسه يتخرم أحيانا، بتوصل لحد الموت أحيانا. فطبعا المفروض إنه نحاول نتجنب ده كله بالكشف المبكر عن قرح المعدة وزيادة الحمض. One last direct message to the viewers regarding the hyperacidity, gastritis, and the ulcers. How they live, lifestyle changes. I will leave you with the camera and tell them some advices.
How to live advices. I advise to enjoy your life. And again, remember what I always say, this is over and over again, quality over quantity. Be careful what you do. Be careful what you put in your mouth. Be careful how, most importantly, stress relief, meditation. Take some time off and basically go to nature.
Moderation in
Moderation,
food.
yes. And that's the best thing I can advise.
Thank you so much, Dr. Prechel. It was very informative. Thank you so much, Dr. Shams. It was really informative. We enjoyed it. Thank you.
Thank you.
الحقيقة رسالة أخيرة إنه دايما نعتني بأكلنا، كل حاجة في المعقول بتبقى كويسة. نحاول نبعد عن فكرة الأكلات الحراقة أو الحامية بشكل كبير، ولو يعني أي نوع من الأعراض دي لقيناها بشكل مبكر نسأل الدكتور على طول، ما نحاولش نعالج نفسنا عن طريق الثقافة بتاعتنا والنصايح اللي بناخدها من بعض، لأنه ممكن أحيانا توصل زي ما احنا قلنا دلوقتي لكومبليكيشنز كبيرة جدا. فربنا دايما يسلمكم من كل شر. بنشكر حضراتكم على حسن الاستماع والتفاعل، ونشوفكم على خير إن شاء الله السبت الجاي وحلقة جديدة من برنامجكم الطبي الأسبوعي وايت كوت.